So following on from that short, I'd like to draw a comparison to pediatrics, where uncertainty is a lot better understood, I would say. An example would be Kawasaki disease, which is a rare vasculitis that can happen in children. So for anyone who's worked in pediatric emergency medicine will know that any child that comes with 5 days of persistent fever without an identifiable source will be referred to pediatrics and will be investigated for Kawasaki disease. The reason is the devastating complications if it's missed, which is coronary artery aneurysms and permanent heart damage that can kind of lead to lifelong issues or be fatal. Now, Kawasaki disease has some good characteristics to explain uncertainty. The first thing is that the complications are devastating if missed. It easily mimics other conditions, so it will often present with things like conjunctivitis, fever, and can easily be mistaken for a benign viral infection. And the third thing is that there are treatments available, which is IV immunoglobulin. So those 3 points illustrate the need to have a low threshold to suspect it. It is rare, but missing it is devastating, and therefore we have to have a low threshold to admit patients for them to be investigated. Most of those patients, especially when I worked in the emergency department, in fact all of them, turned out to have just viral upper respiratory tract infection. But the consequence of missing a child with it is devastating, and so I think that is a good comparison to draw, and we need to maybe think about adults sometimes and adult presentations, which are very common, like abdominal pain, chest pain, in a similar way. And it would be good if secondary care understood that, but they are of course also really overwhelmed. But the biliary colic situation is a good example of that, where there was enough there for me to think this could be something else. I've managed biliary colic in the community many times, but this was a case where those 3 criteria were hit and had to refer.